Good evening, everyone. I'm Dr. Veronica, and I am joined today by Dr. Donna Bartlett. She is an amazing pharmacist, and she wrote a new book called MedStrong. And she's here tonight to give us more information about her book and why everyone needs a copy of this in their home and to share with their loved ones. So, Donna.
Thank you so much. Thank you so much for having me, Veronica. It's great to be here. And yeah, this has been a few years in the making, at least, of the real making of once I started the real thought process and writing down notes. But really, it's been a career path, if you will, unbeknownst to me years ago, but my career path has taken me down the road of geriatrics and specializing in geriatrics and just talking to people about their major lists of medicines and what do I do with this and why is my dad on these meds, why is my mom taking all these, do they need them all those questions that many of us pharmacists have heard over and over again and again. And instead of just thinking about like why I want to come up with a solution and help people come up with a solution to it. And that's why I wrote MedStrong. It's about shedding your meds for a better, healthier you. And it doesn't mean all meds, it just means to optimize your meds. We want to age well through deprescribing. And deprescribing is either the reducing, stopping, or maybe changing a medication to a safer alternative because our bodies change as we age. So, because of those reasons, we need to make adjustments. So, I really wanted to write this book, so I requested a sabbatical. And that was actually a few years ago. The sabbatical had to be requested like a year and a half before I actually took it. So it was a process that was many years in the making, like I had said. And then once I was able to actually sit and write, I had notebooks of notes and stories and various things since I knew that I was going to be writing the book. And at that point, once I started my sabbatical, I was able to sit down, really start the process. But it's people like you that have helped me through this too. And I can't thank you enough for taking your time to be looking through the book as a peer reviewer and really helping me make certain that the message is clear for patients and for caregivers especially.
So I know that you're a geriatric pharmacist and you deal with deprescribing all day, every day. That is the essence of our work as geriatric pharmacists, is we're looking to keep patients safe with their medication use.
Mm-hmm.
As you were researching for this book, was there anything new that you learned or cases that came up that were really interesting and important to share?
Yeah. So working with patients, it's of course always interesting and seeing and trying to, so just a little bit more background of me. I'm a associate professor of pharmacy practice. And so I have a site at a local hospital. And I have my students actually work through patients with me. And we're all investigating the whys. Why is somebody here? What might have made a change for this patient? And I think one of our neatest finds was understanding that I think we glaze over eye drops a lot. And there's this one product, dorzolamide, that's used for glaucoma. And in our older adults, we'll see that being used, but oftentimes our older adults, much older adults, they have reduced kidney function just because age is a factor in your kidney function. The older you are, we know that kidney function reduces over time. And you wouldn't necessarily think about it so much, but those eye drops are still eliminated and need to be eliminated from our system. And they're not recommended for people that have a creatinine clearance of less than 30. So with that, seeing people in the hospitals on dorzolamide with very, very poor kidney function and then having an issue with anemia is one of the side effects that occurs. We're like, whoa, wait a minute, this needs to be stopped. And then you stop the dorzolamide and you can see the change in the patient. And so it's really interesting. I think that was one of the most surprising things that came about in our research at the hospital. I think as pharmacists, we know a lot of like interactions and things to watch out for. We know a lot about QT prolongation and various things like that, or reducing gabapentin as we as kidney function is reduced. But how often are we looking at the creatinine clearance for eye drops? I don't think it's as common of a denominator as we think about other medicines that people are taking.
No, I think that's a great point, and I don't know that I do that well, at least in the retail setting, since we don't have access to labs, but I think that's something that we should have in the back of our minds because our
Mm,
patients do give us clues when we're talking to them and having these interviews about their medications. Other health conditions come up, and if they mention that they've
mhm.
had trouble with their kidneys, that should
Right.
be
Yeah.
lighting up some things for us to go and
Right.
investigate further and make sure that our patients are safe. I
Yeah.
thank you
Or
for sharing
even,
that because that's something I'm going
yeah.
to change in my practice now.
But even for age too, like even if you have someone who's like 85 or 90, you just know that their kidney function is more than likely going to be reduced because we know that part of the equation for understanding kidney function is indeed age associated. So age increases, kidney function decreases. It's just a part of normal aging and functioning. I think the other thing that we need to think about too, and I often say this to patients, and I know that we need to be talking a lot about it um, in trying to communicate with our patients. I think patients have so many barriers to, what do you mean? Like, I've been taking that medicine for years. I can't stop that. And indeed they should, because it's changed over time. So when you look at children from newborns to 20-year-olds, we all know that you're not going to give a 1-year-old the same dose as a 20-year-old. And in that whole entire time, they're basically going to a pediatrician at that point. So that's a 20-year span. When we look at 65 to 85 or even 95, we're looking at 20, 30-year spans. So are you really going to give the same medicine to a 95-year-old as you do a 65-year-old? We need to start thinking more about this. So medicines are working, people are living longer, but there comes a time when we need to really be proactive and start changing these before the accidents, before the falls and the hospitalizations occur and various toxicities. So we need to, everyone, not, pharmacists, uh, every encounter that we have with patients, doctors and specialists, and we need to be thinking about, do we continue or do we deprescribe?
I love that idea of always having deprescribing as part of the conversation and reevaluating it continuously, not
Mhm.
waiting until there's a problem,
Yeah.
which is what we see pretty commonly. It's pretty unfortunate that we don't start taking a good hard look at the medications until there's been an incident.
Right. I think we're really preventative in our earlier years, right? Where we're preventing, issues with blood pressure. We're preventing heart attacks, we're preventing strokes from occurring because we're very concerned in trying to control blood pressure, for example. But I don't know how good we are, and this is, all over the world. It's not just America, it's everywhere. It's international issue where we keep adding on medicines, but we're not preventative in reducing them. We're not preventative in, let's prevent a fall by reducing medicines. Let's prevent a traffic accident by reducing medicines. And I don't think we're really good at that. I think somebody falls and then we get reactive instead.
So how would patients know if they're over medicated or not?
Mm. So, well, there's some you don't, and even and I don't mean to like say it as blanketly as that, but there's no like exact, oh, you've got to stop this right now kind of scenario for patients to know, or even for doctors to know. And that's why this conversation is so important too. And that's why the process to deprescribe is so important. And that's in the book, How to Deprescribe. It's a 5-step process. But with that, um, it's, are you treating yourself like with over the counter products, for example, for more headaches, for dry eyes, for dry mouth? Are you constipated? Whatever reason you might be taking some over the counter product, it could be a side effect of something you've been taking for quite some time. Are you feeling weak or more fatigued than normal? And these things, unfortunately, happen slowly over time. So you might not realize that that certain medications are maybe building up in your body system because you've been feeling, maybe not as energized over so much time, or you just don't seem like you can be as active as you have been compared to maybe a year ago or a couple years ago or something. So we see these very small incremental changes that add up, but we're not noticing them along the way necessarily. But those things could actually be just being on a medicine for far too long, too. I give an example in the book too, where I, and it seems maybe a little bit silly, but I think a lot of people can relate to it, is when women have morning sickness when they're pregnant, right? Some women have it so horribly they're hospitalized, they're so sick from it, and others are just like maybe mildly nauseous, and then or worse, but they like every day they have this, it can be prolonged. Like for me, it was prolonged for this just underlying nausea that I had. And eventually, once that finally lifted, I was like, whoa, I didn't realize how bad I was feeling because I kept pushing it off. Oh, I have friends who've been hospitalized, I'm not that bad, I'm fine. And you kind of go through this mindset of I'm fine, but then you finally feel better, you're like, whoa, I didn't realize how bad I was feeling. So I think we can equate that to medicines too. Like if you've been fatigued and weak or dizzy or whatever it might be, and then that medicine that's been causing that is removed, and you're like, wow, I didn't realize how bad I was feeling. And that's the exciting part of deprescribing, if you will, of working with your providers, figuring this out and feeling better. And that's that shed your meds for a better, healthier you, part of it. That a lot of times, and we hear this from geriatricians, they reduce medicines and people feel better. So, so isn't that great? But it's a process, and it's not, oh, like we said before, it's not one conversation. It's not, oh, you're just going to reduce this a little bit. It takes time. It is a process. You have to invest in it.
Can you walk us through the process that you outline in the book of how do we evaluate our medicines at home and start these conversations with our
Yeah.
doctors?
Sure. So the first is to make a list. And this isn't just a general list, but you hear everywhere, oh, so I have to make a list of medicines. But within this list of medicines, do you know why you're taking the medicine? Or is that a question mark? And you put question marks where you don't know the answer. And this starts the conversations with your providers, because that's what this is. It's conversations and the ebb and flow of information. So the other thing that you think about is, okay, maybe you know what it's being used for. Is it working for the issue? How am I in control? Is my blood pressure in control? Is my diabetes in control? Or whatever it is that you're treating. Is it in control? And do you think the medicine is actually helping you with that? So those are some, questions to ask yourself along, and the process actually takes you through this. The forms itself that I have in the book take you through this process. part of this whole list, which I find really enlightening, is, are you taking over the counters and why? And what are you self-treating? Are you self-treating something? Have you had leg cramps and you heard magnesium's really good? So now you're taking magnesium. So we can decide, like, oh, are you taking a medication that could decrease magnesium and cause you to have leg cramps, like we know the proton pump inhibitors that are used for stomach acid. So that might be an indication that, oh, you're now treating a side effect. So that's what we want to go through, is when we're going through that list, is really try to determine, what are we self-treating, and could it be a side effect that we're self-treating instead of a new problem? So that's the first step. The second step is to go through questions. And I list a whole bunch of questions as to how to be thinking about your medicines, what to ask a doctor, what to ask a pharmacist. What if you're hospitalized, what questions you should ask if you're going to rehab or transitions of care, what you should be asking then. So it helps you define some of these issues, that in some of these red flag areas, that, am I on medicines that could cause me to fall? Am I on medicines that, are making me foggy, brain fog, things like that, that all these things we love to blame on age. Could it be a medicine I'm taking? And we love to blame everything on age, right? Oh, I'm weak. Oh, I'm tired. Oh, I'm, stumbling, whatever it is. And we love to blame that on age. And it's not necessarily the fact. It could be the meds. So then there's the questions. And then we go have that discussion. You have your deprescribe to optimize discussion with your provider. And you make the decision as to, is this medicine, or are these medicines appropriate? Are they necessary? Do I need them all? Are they causing me issues? And then you can start that decision making to say, okay, what can we just deprescribe, and maybe in what order, because we might have to do it throughout a process. So then you use a deprescribing form to go through that. And part of that deprescribing form takes you to that last part of monitoring and follow-up. So if I'm going to need to do reduce the medicine, for example, what do I have to do? Do I need to have lab work done in a certain amount of time? Do I need to see how my mood is? Do I need to test my blood sugars? Do I need to check my weight most day, like every day? What actions do I have to do in order to monitor? And then when is my follow-up with my doctor to see if this has been appropriate? And what really is important is, not everything is going to make us feel differently. And so sometimes no change is actually a positive outcome, because if you can reduce something without there being really any change, did you really need it? Or is it even working for you at that point in time? So if you are reducing something, say an over-the-counter supplement or something like that, for example, and you're not really noticing a change, then you might not even need that product at all. But work with your prescriber as you go through this, and your providers. Work with your team of healthcare providers and while you go through this, and take it step by step.
I think that's really good that you said sometimes no change can be a good thing, that we haven't done any harm by removing it, but we're also reducing the risk for future harm by having something on board that's not benefiting us, but it's there to cause an interaction with something else, or there with the potential to create side effects later. So I think that's huge, to stress that taking something away and having no change is still a good thing.
Yeah. Yeah. And it's weird for us too, as providers, to think this way, because when we look at studies, we're always looking at improvement, right? And we're always looking at outcomes, but the outcome could be no change. And that's something new for us to be thinking about too, especially in this deprescribing world. Yeah.
I like that you mentioned the list of questions that you give to patients to ask at different points when they would do this. So you mentioned transitions of care. So after a big change, like after an ER visit, or maybe you're going from the hospital to back to home, that's a transition of care. And there's different questions that are important when you're moving from different types of care.
Absolutely. And I just think it helps patients not think like, oh, I can only talk to my primary, or I can only talk to the doctor who prescribed this about this medicine. No, you can talk to the hospitalist about it. You can talk to, your rehab doctors about it if you're in, some type of post-hospital rehab clinic type of areas. So you can have these conversations with lots of people and and keep moving in the direction of reducing unnecessary and inappropriate meds.
How often do you think we should be doing this process of listing our meds and going through, do I know what everything's for? Do you have a recommended frequency for how often you do that, or that you recommend patients do it?
Well, I would definitely say at least yearly when you're doing your physical. However, I really think every time, and it might not be every medicine every time. Sometimes it's good just to target something. Like if you're kind of questioning something, maybe bring that one up that interim time with your doctors. Like, I've been on this for a really long time and I'm not quite certain if it's really helping me anymore. Could we discuss whether or not I need it? So it doesn't have to be every single med on the list all the time. I would do that at least once a year. But every time you go and have conversations with folks, it's a good idea to be thinking about, am I treating a side effect, or is this a new problem, or if I eliminate something, will I feel better too?
So every encounter with your doctor, be thinking about opportunities to take something away.
Yeah.
Not that we have to take something away, but have that in our mind that every time we see someone on the healthcare team, there's an opportunity to optimize our care, and sometimes that's with less medicine.
Right. And I think so often we think, oh, I'm going to the doctor's, maybe it's an interim, not feeling great. I probably am going to have something new added on, when, how open are we to changing the conversation to, you might feel better if you stop this medicine. You might feel better if we reduce this medicine. And how ready are people to hear that, especially if it's medicine they've been taking for a long period of time? We'll hear often, I've been taking that forever. Why would you stop that? And it could just be that your body is not functioning the same way that it did, because our bodies change as we age. So sometimes we just need to make those adjustments accordingly.
I love the example that you gave when we started of children, how we dose them differently through their progress into adulthood. And so why wouldn't we also change our dosing? I think that was such a great example for us to be thinking about why we would need a dosage change as we get older, especially knowing that our kidneys don't function as well and our liver doesn't function
Right.
as well. Doesn't mean it's diseased, but it's just not performing like it was when we were 20.
Right. Exactly. Exactly. It has some miles on it, but
Yes.
but that's okay. I mean, we can still be healthy. We just have to be aware. Yeah, for sure.
So when you wrote MedStrong, did you have a personal experience or a particular patient that really inspired you to create this resource to share with the world?
I can't necessarily say there's a specific one. I think it was I think being in the outreach program, I worked in the pharmacy outreach program at Massachusetts College of Pharmacy and Health Sciences for about 11 years. And that was really working with a lot of seniors, because a lot of this, we did a lot of outreach with senior centers, and we did a lot of Medicare work for people and with affordability and access to medicines. So we would see and talk with a lot of older adults, and hearing their stories, seeing their med lists, seeing pill boxes filled to the brim, not correctly. Um, just it was mind-boggling to me. And then always hearing those questions, even as a dispensing pharmacist for 20 years, it was, why am I on all these meds, or why kind of thing, and no real answers. So then specializing in geriatrics, it just kind of has become, I don't know, a journey for me more than anything. And I just felt that I was saying a lot of the same things, and there were a lot of barriers, a lot of barriers. And even if I would call a doctor's office and say, oh, I don't know how necessary this medicine is, there'd be barriers that way too, because it's just not it, especially, so many years ago, it really wasn't common practice just to be reducing meds. They're not complaining about it. Why would I change it? Or the patient's doing fine. Or, various scenarios that you would hear. And it's just like, and then I started getting into the Falls Prevention Coalition in Massachusetts, and just hearing those fall statistics and seeing the charts grow year after year as to more people falling. And then at 85 and older, the curve really jumps up for increased risk of falls. And knowing that those falls are, risk after risk after risk, it's like blocks that you put on top of one another. And as the risks add up in the tower becomes taller, it's more likely that the tower is going to tumble. If we can just start taking away some of those blocks of high risk meds and things such as that, and make a difference in people, and they feel better, it was like, wow, we're allowing people not to fall. We know falls can be prevented. So with all of these things, but really just geriatrics in general, and my journey through retail to outreach to specializing in geriatrics to falls prevention, it really helped me form the path for the book.
What are some of the high risk medications for falls that our patients should be thinking about and are important to have deprescribing conversations around? Are there some standouts?
There are, but what I like to always say, and I will share the standouts, but what I want people to understand is that something that someone takes might be very appropriate for them, and that same medicine in somebody else could be extremely inappropriate. So we can talk about these high risk meds, but somebody might really need it and benefit from it, and somebody else may no longer need it, and it has become more harmful for them. So that's, before I give some ideas of these medicines, it really is individualized, and it depends upon someone else, your health status, other meds that you're taking. There's a whole number of things. That's why it's important to have these conversations, and why it's an individualized approach. And it's difficult to study, but we do know that there are high risk meds, and those meds are on the Beers list and the stop list, for example. But some of them are like the benzodiazepines, medicines used for anxiety and sleep. They're the anticonvulsants, and they might also be used for pain, like gabapentin for neuropathy. But also we see people on anticonvulsants that might have had a seizure in their 20s or 30s and have never come off of their anticonvulsant meds. And there's reasons for that. One, fear that they might have another seizure. But we know that after 4 years of being seizure free, you might be able to start reducing those meds. But what does that mean for the patient? And how do we understand whether or not a patient is appropriate or not? So it's scary for patients. And you can see those barriers that I don't want to have another seizure. Of course you don't. So you can see how this accumulates over time, and like people are unwilling to stop a medicine. But those are some big ones. There's also, when I talk about um, the, so sleep aids are another one. Things like the Zolpidem, Z drugs, we call them. Those can have very poor effects for folks. And then another prescription family of medicines are the antipsychotics. We see that used in older adults that might have dementia and behavioral issues, or psychotic kind of breakthroughs because of dementia. And those are not ideal products either for seniors. So a lot of those can cause increased risk of falls or other issues, more confusion, and sometimes QT prolongation, where we see the effects of that in EKGs changes. So there's a lot of things that can affect older adults. Anticholinergic drugs are huge, and a lot of medicines have anticholinergic properties. So things that we use for urinary incontinence, for example, those are anticholinergic. So thinking dry, but other products that cause us to have dry mouth, dry eyes, if it could be that they're on medicines that have these anticholinergic side effects, and also increase the risk of falls and cognition, tachycardia, causing arrhythmias. Arrhythmias make people fall. They cause syncope and cause falls too. So there's many meds, but if we're dosing them appropriately, they are appropriate and needed for people. They can be used, but we don't want people just to be continuing these needlessly.
Have we left off anything important about your book? Did I forget any questions or anything that you want to share?
So I just think it's important that we think about deprescribing to optimize. So I just want to say and voice again that the book is not about removing every single med. It's about taking the meds that are needed for you. You might need to control various disease states, but we want to make certain that we're doing it optimally with the best medicines, only the necessary medicines at a correct dose, and then always be checking on that too. So deprescribe to optimize. We want to do. We want to make certain that we're doing that. And in the process that I have, that medication optimization plan, it's actually it's the acronym for it is MOP. So, we need to mop, we need to make certain that we're cleaning up our med lists and really, optimizing our meds so that we can be healthy and vibrant and keeping older adults upright and in the community. So I think that's all really important. And those are really important take-home messages for me.
Very good. Thank you so much. Happy, do you have any questions for Donna?
I was actually thinking in terms of like drug-induced nutrient depletion. Just as we try to support older adults. But then that could add its own pill burden. So I was just thinking about how do we navigate that as part of the deprescribing process.
Yeah. So sometimes we'll see that people have reduced appetites, they had difficulty swallowing, things such as that. And what I often like to look at is that anticholinergic burden in that case, because if you have dry mouth, then your throat is dry as well. You can't eat well, typically. You do have difficulty swallowing at that point, and then people are losing weight. So maybe it's taking off those anticholinergics, because getting those nutrients in is going to be important to do that. And of course, there's other meds that we know. There's two meds in particular that we might see older adults on now, especially if they've been taking it for some time. Fluoxetine is one, and that one of the biggest side effects in older adults is a decreased appetite or anorexia in older adults with fluoxetine. So if they still need an antidepressant or anti-anxiety med, they could just switch over to a different SSRI like a sertraline, which isn't as long lasting or acting in older adults. And they could still get the therapeutic needs, but be able to not have that side effect of anorexia and weight loss that we see. The other one is digoxin, and we know that we need to be checking blood levels for that, but that is another one that reduces appetite and can cause issues that way. So those are two big ones that we might see, especially older adults, 85, 90-year-olds on, that just because they've been taking it for years and haven't had that reduced or changed.
Well, thank you. I think I was actually thinking specifically in terms of where supplements are added on to address nutrient depletion, and that could end up kind of adding more pill burden. So it's kind of
right, absolutely. So I think what happens in these cases is people are like, oh, we have to add on supplements, when really they should be looking at why that nutrient depletion is happening. Is it because someone's been on a proton pump inhibitor for a really long time? So I guess what I'm trying to say as an answer to your question is trying to figure out that nutrient depletion. Why? Is it because of side effects of other medicines that people aren't getting their nutrients because they're not eating well? Because we know that appetite in general can be reduced. People don't necessarily have that same thirst type of sensitivity as they age. They lose that sense of thirst. So they might not even be taking in fluids as they should. So when you're like dry anyways, because your older adults tend to have less fluid intake, and then you have that thirst issue. So you're getting like these more and more types of side effects. And so you're depleting your nutrients because you're not eating as much. But with that, and I do agree, a lot of people do go to supplements. And to me, when we look at polypharmacy, we'll look at 5 or more meds, and it's just not prescriptions. It's all meds, it's all supplements, it's herbals, it's anything over the counter plus the prescription. So you're absolutely right that all of those supplements, they can certainly play a part in that puzzle of necessity or inappropriateness even. But why are we looking at that? Has somebody, like I mentioned before, on a proton pump inhibitor and their magnesium's depleted? Because after a year, it's in practice, you should have your magnesium checked if you've been on a proton pump inhibitor for at least a year. And then people get into trouble with arrhythmias and muscle cramps and aches and things such as that because of low magnesium. There's also issues with B12 and proton pump inhibitors. So you're absolutely right. There's a total burden, but if we can see if it's a med issue first and take care of that side of it, I think that's an important part of looking at deprescribing versus adding more on. I hope that makes sense as to where I was going with that answer.
Yes, it does. Another question I had was, what has been your experience trying to deprescribe antidepressants or just psych meds in older adults? It can be a bit of a challenge, especially when trying to manage treatment-resistant depression that doesn't respond to kind of the safer SSRIs, and you have to start considering like TCAs or kind of the meds that are on the Beers list.
Yes.
It gets challenging.
Absolutely. So A couple of things. I think that folks are concerned or kind of hands-offish with deprescribing behavioral medicines in general. And again, like what I see happen at the hospital is people come in and they've been on like citalopram or escitalopram, and they're on these high doses for their age, and they have QT prolongation, and they're in for some type of arrhythmia. And I'm going, okay, time out. We've got to reduce these medicines. They're, 85 years old and they're still on 40 milligrams of citalopram when they should be at 20, kind of thing. So bringing that up to the doctors. And if you have a good reason for reducing those, I think that can be like to have that backup, that other reason to make it safer for older adults. Of course, we have to reduce these slowly, for sure. There is resistance too, of course, but it is recommended that if people are put on an antidepressant or an antipsychotic, that especially the antipsychotics, they need to be reviewed. I believe it's every 4 months, if I have that correct, to see if it's still necessary, because sometimes it's episodic that somebody is having issues like during their dementia phases, and they don't necessarily need to stay on the antipsychotic. For the resistant depression, that is tricky. And I'm not an expert in that area, I have to say, but instead of just constantly adding on, I think we really do need to be thinking about reducing and maybe using some other therapies such as music therapies. And, is it isolation issues, things such as that we might be able to help somebody with. Is there caregiver needs that are necessary? So I think it's a really complex question, but I don't think necessarily adding on and continuing to add on and getting into other issues it can be problematic. So like, what's their mobility? Are they frail? Can we move up their frailty score and things like that to help them be able to move and enjoy and kind of get back some of that quality that would help them get through that depression.
Sounds good. Thanks so much, Donna.
Thank you so much. Great questions. You're challenging me.
Well, that brings us to the end of our time. Thank you so much for joining me tonight, Donna, and sharing your expertise and sharing about your book. Will you repeat the whole name of it for us?
Sure. So it's MedStrong, Shed Your Meds for a Better, Healthier You, Aging Well Through Deprescribing. I know it's long. It's a lot of subtitles. But
and where can we buy your book?
So there's a few different ways you can get my book. Of course, there's the Amazon, where you can buy it through there. You can go to my website, donnabartlett.com. And there's more information on deprescribing. That website is all dedicated to deprescribing. You can find out more about me and more about deprescribing and the book at donnabartlett.com. And so those are some of the main areas where you can find my book.
Awesome. Yes, go to her website and get on her email list because she sends out really good emails. I really enjoy reading her emails. I'm always in her inbox going, oh, Donna, I just read that blog post that you wrote and it was so good. I learned something. And I'm excited for y'all to get that in your inbox and to get a copy of her book.
Yes. Thank you so much. And like I said, Veronica, thank you for the role you played in helping me with the book too.
Thank you. It was an honor to read the work and then be able to share it with patients in the world.
Thank you.
Have a good night.
Okay.
Good night.
You too. Good night. Take care. Thank you so much.
Take care. Thanks, Donna. Thanks, Veronica.
Yeah.
Bye.
Thanks for joining.